Good afternoon, everybody. It's my pleasure to present our proposals for a centre for planned orthopaedic surgery based at Colchester Hospital. This proposal is part of a bigger programme of work that we call Building for Better Care. That's supported by nearly £70 million of central government funding. That has to focus on two key areas of our work. The first is urgent and emergency care, and a lot of that is focused around Ipswich Hospital and includes a new MRI and CT scanner, a new emergency department and urgent treatment unit at Ipswich Hospital, and redevelopment and expansion of the specialty assessment units at both hospitals. Specialty assessment units are part of the emergency care pathway. If you are assessed in the emergency department, A&E as we sometimes call it, and you need to see a physician or a surgeon, the quickest way to get that specialist assessment is to transfer you through to a unit run by that specialty. We're expanding the size of those units in this project. And finally, a modest reconfiguration of the emergency department at Colchester Hospital. The second main strand of work in this programme is what we're talking about today, and that is planned care surgical services. And there are two parts to that. The first is the orthopaedic centre that we're talking about today, and a second but important part is the day surgery facilities at Colchester Hospital, which are now approaching the end of their usable life and really need to be re-provided. So I've heard occasionally during this process some people suggest that we are downgrading Ipswich Hospital, and I think that couldn't be further from the truth, really. So I've just summarised on this slide some of the many developments that will be taking place at Ipswich Hospital in the next 5 to 10 years. So I've talked about the first three, which are the emergency elements, but we will also be redeveloping the breast unit, the children's unit, dermatology, neurophysiology, building some new theatres for keyhole surgery and improving the outpatient facilities. And there is a whole long list of other things as well that I just didn't have space on the slide for. So it's, I think, to me, absolutely clear that if we were downgrading Ipswich Hospital, we wouldn't be spending £35 million on a new A&E. So I thought that was helpful just to summarise that. So why are we making these proposals around orthopaedic care? The main reason is that we just don't have enough capacity at the moment in our existing wards and theatres. And that's illustrated by some of the numbers on this slide. So in the last year, our average cancellation rate for patients who had a booked date in theatres was nearly 1 in 3. And not all of those patients had received a letter confirming the date, but the fact that we'd booked them into the system and then had to reschedule them is an indication of just how much pressure the system is under. The main cause of that is that the bed we wanted to put the patient in who was going to have planned surgery has been occupied by an emergency patient and therefore is no longer available for planned surgery. The net result of that is that we're doing a lot less inpatient operating than we used to. So last year we did nearly a quarter less operations than we were doing 5 years ago as an inpatient. Our waiting times have gone up at both hospitals, and for example at Ipswich Hospital at the moment you would wait an average of 22 weeks from referral to your surgery. The national average is 14 weeks. So you can see that the service is under considerable pressure. And because of all of that, the waiting lists are going up. So we now have nearly 50% more people on the waiting list than we had 18 months ago. I think all of that just illustrates the degree of pressure that the service is under with its current capacity. And I think it's not only frustrating for patients if you wait a long time or if your operation is cancelled on a date when you've got all your plans in place and your family are ready to support you, you've got somebody to look after the dog. It's very frustrating for our staff as well, who are all geared up to do planned operations, and then at the last minute are told, I'm sorry, you can't, because we have to put emergency patients in those beds. So the centre itself would have at least 48 new inpatient beds built to the latest NHS specification. And that means that at least half of the beds would be in single ensuite rooms, and the remaining beds would be in 4-bedded bays. And just to give you an idea of the size of that, if you're familiar with one of our current bays, they have 6 beds in usually, and the new bays would have 4 beds in roughly the same space that we put 6 in now. And that extra space, it's very nice. It creates a nice environment for patients, for visiting family and for staff. But it's also important for things like reducing the risk of infection crossing between patients. The extra space around the bed allows for therapy equipment to be brought to the bedside, so we can start to rehabilitate patients from their bed rather than having to take them out of the ward to a separate area to do that. And it also, particularly in the ensuite rooms, allows us to have a bed for a visiting relative if they want to come and stay with the patient. So there are a lot of advantages to that extra space. It would also include up to 6 new state-of-the-art, ultra-clean orthopaedic theatres. Initially there would be 5 because we don't think there is enough activity initially to justify 6, but there would be a space for a 6th theatre to be added when there is need for it. And the centre would focus on things like joint replacement procedures. There are a whole list of other types of procedures that would be done there as well, but the common things that people are familiar with are hip replacement and knee replacement. And importantly, the centre would be very well suited to undertaking revision surgery, which is when we have to redo a joint replacement several years down the line after the original replacement has worn out. And that is a more complex procedure. So there are a number of benefits. I've talked really about the first one, which is reducing the risk of cancellation, because this will be a centre dedicated only to planned care patients. And that will reduce the waiting time from referral to surgery, because every time we cancel a patient, of course, we don't just push that patient back, but we push back everybody behind them in the queue. So overall, reducing cancellations will reduce waiting times. We expect that this fantastic state-of-the-art facility will also reduce the length of stay that patients spend in hospital when they have their operation. This has been coming down steadily over the last 20 years. When I was a junior doctor doing orthopaedics, patients would routinely stay a week to 10 days after a hip replacement. And these days they spend 3 or 4 days in hospital. So it has come down fairly steadily, but this state-of-the-art facility will continue that trend. It says better clinical outcomes here. I don't want you to go away with the impression that our clinical outcomes are not already excellent. They are at both hospitals. However, we know that variation in clinical practice is a cause of poor quality. And creation of a centre like this is a great opportunity to standardise to the best practice across all of our surgical teams and supporting teams. And that will maintain, if not improve, the clinical outcomes for patients. I've spoken about the physical environment already. It's difficult to imagine just how spacious and commodious this new facility will be. It really will be an impressive facility for our patients. Importantly, it will free up much needed space for other elements of our services, particularly at the Ipswich Hospital site. So as well as being under pressure for planned surgery, quite often our emergency patients, say with a hip fracture, which is a common emergency presentation, will come into hospital and we know they need to have an operation to stabilise the fracture or to replace the hip joint. Because we only have one emergency orthopaedic theatre at both sites, there are quite often days when there are more patients needing those procedures than we have space for on the list, and therefore they wait longer than we would ideally want them to. So by moving the planned surgery out, we will free up some of the existing theatres to offer more space to the emergency patients. And at Ipswich particularly, we'll be able to offer more beds for those emergency patients as well. It will be a specialist centre. It will be state-of-the-art, and we expect that it will attract and help us to retain top quality staff to provide the best care for our population into the future. And of course, when top quality staff come, they will want to undertake research and bring innovation in practice with them. And we think those are all great things for the people that we serve. So why are we proposing Colchester Hospital? Well, I want to be absolutely clear that there is space at Ipswich Hospital to build this facility. However, there is no space at Ipswich Hospital where we would not have to knock something else down in order to build this facility. And we'd then have to rebuild the thing we knocked down, and that would consume more money with no additional benefit. It would just be a like-for-like replacement. So we're not looking just at whether we can build it in a particular location, but whether it's also affordable within the budget we have to be able to build it there. So the funding for this is substantial, but it isn't infinite, and therefore we have to fit within that budget. So having done that process, and we looked at a whole range of options, we looked at whether we could build it where Toys R Us is at the Copdock roundabout, and we looked at both Ipswich and Colchester sites to try and find a suitable location. The Copdock roundabout isn't the right location, because it's great if everything goes well, but if you have a rare but serious complication after your surgery, you need access to other types of medical care and diagnostic tests very rapidly, and therefore our clinicians felt that if we're going to build a centre like this, it has to be on one of our main hospital sites. So we've looked at all the options at Ipswich, and we haven't found one that is both feasible and affordable, and the only location we could find that met those criteria is at Colchester Hospital. The second reason is the day surgery that I mentioned at the beginning. So if we build the centre at Ipswich Hospital, it means we need to build a brand new facility at Colchester Hospital for day surgery, and that just ends up costing too much money. If we build it at Colchester Hospital, because we're moving some of those services out of existing space at Colchester Hospital into the new centre, we are able to put day surgery into the space that is created in an existing building, and therefore it's affordable. And the final reason, which is a little more subtle perhaps, is the number of people needing treatment around the two hospitals. So at the moment, roughly the same number of people get treated in Ipswich and in Colchester each year. There are very slightly more at Colchester, but it is very slight. However, the population around Colchester Hospital over the next 20 years will grow by about twice as much as the population around Ipswich Hospital. And particularly it will grow in the age groups where people need these operations. So that means that the difference between the number of patients needing treatment around Colchester and Ipswich gets much bigger over the next 20 years or so. So part of the rationale is that when we build this centre, we want as few people as possible to have to travel further to get their treatment. And for that reason as well, we have proposed Colchester Hospital. So on the Colchester Hospital site, if anybody is familiar with that, this is the main block and the main entrance is here. And the blue area is the site of the new proposed centre. This is the northern approach road from the A12 somewhere up here and the football stadium. There is a park and ride facility near to the football stadium which stops just outside the centre. Down here there is a mainline train station connected directly to Ipswich. With our local government partners in Essex, we expect to be able to create a new entrance right next to the centre from the northern approach road to give better access by car, and there will be some parking outside the centre, particularly for disabled patients and drop-off. So we think this is a good location. I think the other thing to say about this is that it's close enough to all those other medical services in the main block should they be needed, but it's just far enough away to make it unattractive for putting emergency patients in there, except perhaps in the event of a major incident or coronavirus or something like that, where there is a rare but very serious upsurge in demand. And of course, in those circumstances, we'd use every space available. But I think it's important that it's slightly separate from the main facility for normal running. There's a lot of things that wouldn't change. So your outpatient care, your diagnostic tests, your scans, x-rays, blood tests, etc. would remain at your local hospital. Ipswich will continue to be the regional centre for spinal surgery. Day surgery for orthopaedics will remain at Ipswich Hospital. Emergency orthopaedic surgery will remain at Ipswich Hospital. Follow-up appointments will continue at Ipswich Hospital. And importantly, the consultant that you see in outpatients will be the consultant and the team that perform your surgery at the new centre. So really the things that change are your inpatient stay for 3 or 4 days at the centre and the reduction in the risk of your surgery being cancelled or delayed. We also think there is an opportunity to reduce the total number of journeys that people make to the hospital. So a project like this is a great catalyst for reviewing the way we do things. And we will, during the design of this, detailed design of this facility, we will work with our clinical colleagues, doctors, nurses, therapists and supporting services to review the whole pathway of care. The current pathway of care begins with referral from the general practitioner, and there is a community assessment that takes place before you're seen in hospital. But after that, patients can have to visit the hospital for up to 6 times before they have their surgery. Now, this is very variable between different consultants and between the 2 hospitals. So that already tells you that our processes aren't standardised currently. We also think that after your surgery, there are a number of visits for consultant follow-up and for rehabilitation. And again, we can look at whether all of those are really necessary. So our new pathway might have, it will still have the GP and the community assessment steps, but we think there's more scope for introducing one-stop initial assessment clinics where you would have your diagnostic tests and then see the consultant, so that in your first visit you could get a diagnosis and start your decision making about whether you want surgery, if that's necessary. We also think there's scope for more combined clinics with other medical specialties for patients who have diabetes or heart disease or lung disease, for example. You would have your surgery at the new centre in Colchester. And then for rehabilitation, we also think there's a lot more scope to do elements of rehabilitation in community hospitals and for some patients even in their own home. So there are a number of hospitals in the UK now that are providing some elements of therapy, physical therapy particularly, via video link, for example. And I think over the next few weeks and months, we're likely to see a lot more patients enjoying parts of their care in the comfort of their own homes via video. So that may seem a lot less unusual to us, I think, by the autumn of this year. And we also think that we will look closely at whether follow-up is required for every patient. So the vast majority of our patients having follow-up is a conversation that goes roughly along the lines of, how are you? Fine. All your tests are okay. We'll see you in 6 months, which really, although it might be comforting, doesn't add a lot of clinical value to the interaction and could probably be done by phone or by video. So we think we can look at the number of follow-ups, and that all of that together, we think, will shorten the total pathway of care and reduce the toing and froing to the hospital. So how many patients are affected by this proposal? Last year around our 2 hospitals, just over 3,400 patients needed planned orthopaedic procedures of these kind. Just under half of those patients attended Ipswich Hospital and would have the location of their care for surgery changed to Colchester under these proposals. The centre would see about 14 admissions a day, and about half of those would be coming from the Suffolk end. But it's important to recognise that the number of people needing treatment will grow significantly over the next 20 years by just under 1,000 patients. And we're struggling with the numbers we've got already. So it's not just a question of managing the patients needing treatment at the level of patients needing treatment at the moment. It's that significant growth that we have to cater for. It's clear that there will be some impact on some of our staff by changing the location for surgery. And we have been engaging our staff for some time about these proposals. However, this part of the process, the public consultation, we have to do it by law and by guidance from the NHS at an early stage in our planning. So there is a lot more detailed planning we need to do with our staff about how rotas are composed, what skill mix of staff is required at both sites to deliver all the services we need, to consult with our staff about any changes that might be made to the way that they work. There is plenty of time to do that, and I'll explain that in a minute. So the consultation itself, as I explained, we're consulting only on a single option because we could not find another option that was both feasible and affordable. However, it is really important to us to understand your views on the proposals and their impact. We've heard a lot from the events we've done and from engagement before this public consultation about transport and access to the sites, as you might expect. So we would really like your thoughts on what those issues are, but particularly if you have any good ideas about how to reduce the impact of travelling a little further on our patients. And we've had some very creative thoughts from our attendees at these meetings so far, so there's a little challenge for you. There is a lot more information on our website, including travel and equality impact assessments. There is a summary of the business case, and particularly there's a very helpful report from the Independent Clinical Senate for the East of England. Clinical Senates are bodies set up in every region of England, made up of groups of independent clinicians from a wide variety of specialties, and their role is to give a view on proposals like this, where we want to change the way we deliver services, with that independent clinical perspective, to advise us on whether they think our evidence base and our rationale for change is sound, and also to make any suggestions for improving the proposals. So the report we've had from the Clinical Senate has been extremely supportive of these proposals, including the location of the centre, and they've made some very helpful recommendations which we will incorporate into the detailed design, but I would encourage you to read that report. As Rebecca said at the beginning, we're holding 11 public meetings. This is number 10, I think. And we have one more next week in Stowmarket. And there is social media activity going on as well. So the timeline for the decision, the consultation closes on the 1st of April. We are then in the pre-election period for local government elections, if those go ahead as planned. Once all that's out the way, we will hold a stakeholder decision-making workshop at which there will be representatives of the public and patient groups, local government members, there will be commissioners and staff from our organisation and the local health watch organisations represented. And they will help us to bring together all of the feedback from the public consultation and formulate some recommendations to the CCG's governing bodies, who will meet hopefully in the early summer. I have to say hopefully before everything now, don't I? If we are successful in gaining approval from the CCG governing bodies to proceed, we will then begin the development of the detailed business cases and the detailed planning that I mentioned earlier. That will take us probably 12 months to complete, so there's plenty of time to do that. The contract for building, therefore, would only be awarded in 2021 or 22, and the building itself will take about 2 years to build, which means it opens in 2024, which feels like quite a long way away to me, but that's the time these processes take.